Okay, brilliant. Good evening. It's now 16 minutes past. I'd like to mind item 1. Haven't seen any Tammy Henry, our Thurrock coalition member, have left the committee, and I'd like to welcome Neil Woodbridge, substitute me. Item 2, the minutes. I move the minutes to the Health Wellbeing Overview and Scrutiny meeting held on the 1st of January. Approved as correct record. Does any member have any comments? No, that's marked as approved. Item 3, urgent items of business. I have not agreed to any items of urgent business. Is there anyone wish to raise any points on the briefing notice? Okay, item 4, declaration of interest. Does anyone have any declaration of interest?
There's a standing one that I wrote for the NHS for the ambulance service, but there might be some.
Okay, items raised by Health Watch. As Kim sent her apologies, I move to item will be actually item 7. Oh, we do item 6. Sorry. Yeah.
I will do it then. Sorry.
Okay, so as we grab all the people waiting, I'm allowing 15 minutes. So this is item 7 on the agenda. The overview and responsibilities portfolio. Adult community. I'm allowing 15 minutes for this item. I'd like to welcome Professor Wellbeing this evening to the meeting to ask her to provide an overview of the portfolio.
Thank you, Chair. Jen's just said something.
Oh. I don't think I'm going to be able to. Can anybody see that? Online?
Yeah.
Yeah.
So, okay, thanks, Chair, for inviting me tonight. I understand that you'd like me to present on responsibilities from our portfolio. It's a bit of a whiz through, but I'm happy to take any questions at the end or have meetings with anybody afterwards or email, whatever you want. So, like, I was elected to represent Thurrock residents. It's my community, it's where I live, it's where I work, and if I get time, it's where I play. So this is what I see as my responsibility as a councillor, to make sure residents' choices and their opinions are heard by council and work out the best way forward. Hopefully the slide speaks for itself, to support, guide, signpost and recognise it's not always Thurrock Council that can help. Sometimes, as we know, we don't always want to hear the answers we're being given. So not only are we there to challenge council on the answers given, but it could be to support residents to recognise that council can't do it and defend the answer and to try and help in some other way. So I need to understand how council processes work so I can help navigate residents around or through that. We just press again. And really, as a cabinet member, I would say it's exactly the same, it's just intensified. Go to the so what's the process then? As I understand it, to quickly summarise it, it's Cabinet sets the overarching priorities, then Council finds a legal, feasible, viable, sustainable way to do that within a budget. Council presents their ideas and findings of how to achieve priorities via options and choices within Cabinet reports. The reports are made public. They come to overview and scrutiny so that residents and cross-party councillors can ask questions, make recommendations, take part in consultations, raise petitions, basically have their voice heard before Cabinet makes a decision. And thus providing us and Council and Cabinet understanding so that we can make the right decision and feel we've made the right decision under the circumstances. So my overarching priorities for adult social care and communities is for residents to have the best possible care by improving preventative care to enable us to stay in our homes, living independently and experiencing a good quality of life for much longer. We can do that by working together and supporting each other within the community as well as through good care packages. And I put some key words on the slide for you there, and I tried to sort of pick a top 5 and highlight when talking tonight, and thought that, well, it would be collaborative working, trust, flexibility, communication and delivery. But then thought, no, actually, dignity, understanding, independence, inclusion are all just as important as is support and engage. So really, it's everything. Next slide, please. So how do we make it work? I say we because it is a mammoth team effort, right from the CEO through to partners, voluntary services, residents and members. And I play a small part in it too. So this slide starts with how I see Council makes it work. By raising awareness, by celebrating or commemorating moments in our history, meeting residents face to face within the community, being that first line of preventative care, talk shops, local area coordinators, library staff and volunteers, drop-ins at supermarkets and church halls. I cannot stress how important these are. Direct access to social workers, housing officers. When, whilst you're out shopping, an elderly resident can then get help for a grab rail, or someone being able to report that a child or an adult they think might be being abused or homeless, and when you can take that first step to mental health help or care that you might need. To promote joint working with partners like the NHS through the Better Care Fund, sharing budgets and best practices, and likewise with voluntary services through targeted grant funding, such as the Community Environment Development Fund and Voluntary Sector Development Fund. Facilitate and bid for other funding, such as towns funds, free ports, community-led local development fund. All of these are aimed at ensuring Thurrock sustainability with better job prospects, better investment, leads to better health and well-being. And then the real nitty-gritty of managing budgets and spends and understanding budget pressures. Most importantly, and what I think we as residents and councillors probably underestimate, is the work of teams like public health and adult social care and housing to keep Thurrock ahead of the curve and on track for better outcomes. For example, during COVID, we were giving PPE to care homes before the government said we should. We set up an emergency call centre and armed an army of volunteers within days, something most of Essex looked at as a model for good practice. We set up oats houses and early discharge from hospital to free up hospital beds, but taking care of those that couldn't be taken care of at home. We had that up and running before the NHS and government knew that they would be needed. We already knew. We piloted and we've proven that health and wellbeing teams work. We're rolling them out across the borough. We're working with partners to form those teams, and we've been on the journey for a while whilst other authorities haven't even started. And it was only last week that government produced a white paper saying local authorities in NHS need to work together to resolve preventative care issues. We can go to the next slide, please. So what's my part in that? I meet regularly with officers and directors for briefings, read reports, ask questions, try and gain understanding, make sure that what I've understood is correct in my understanding. Inform cabinet members, get answers to our questions, voice ideas, challenge officers and directors, provoke conversations and thoughts to understand the consequences of our actions. I meet and talk to service users, service providers, residents, community stakeholders, voluntary services, charity organisations, anyone that will talk to me about something, as well as cabinet members and fellow councillors. I try to look at options from all perspectives to gain some understanding and direction. I consult with those affected before decision making, try and process in my small brain, look for compromise and look for what we can do for the best to improve lives and services wherever possible. And then when the decision's made, defend it. Next slide, please. So every person and every organisation in Thurrock has a part to play. Like weekly, monthly meetings, ad hoc meetings with various directors, officers. I attend the Health and Wellbeing Board, the Adult Safeguarding Boards, things like funding panels and the Community-led Development Panel. It's led me to meet many community stakeholders, and these are ways to hear issues and build relationships and trust, as well as to consult and ensure that we spend taxpayers' money wisely. Also, I'm not afraid to share. Sometimes I think it helps to be real and perhaps show some vulnerability to help staff and others understand the consequences of actions, working practices, and also to show you can empathise and understand situations residents find themselves in. Next one, please. This is just a small sample of people I've connected with recently. For example, funding panels have led to good constructive conversations with various organisations like One Community, Thurrock 100, Engage, Port Tilbury, Department of Work and Pensions. Remembering Srebrenica led to meeting men and women within our resettled Bosnian community, still traumatised today and suffering from the violence and the atrocities that occurred there. Some of the visits I've made are to meet staff and service users, as well as the facilities we provide. So I've also visited daycare centres, residential homes, assisted living, spoken at conferences for staff and health partners. It's not just residents that need supporting. We should remember that a lot of our staff are also residents and work hard to do their best for Thurrock and sometimes need our support and acknowledgement for that. Next slide, please. And lastly, I just want to say, like everybody, I'm human. I do things to the best of my ability. I try and make the right decisions for the borough. Any decisions that I make, they'll be popular with some, they won't be popular with others, but it sparks a conversation. Hopefully we get to the right thing. But I think my main priority is, if I get it wrong, to recognise I'm wrong and start to put it right. That's it really. I've kind of left a bit of time for questions.
That's a brilliant breakdown of your role. Councillor May, shall I take a copy of your next I mean, it's really comprehensive breakdown of your role, and it's so well done. Is there anything there that you feel that would help the more agency or role better? Or would you with that machine people access? So you want to bring that to change?
Sometimes it's about having trust, and that comes from building relationships, to cut some of the red tape that we put around ourselves to make it safe and to try and make sure we've got the right processes. But that can really tie us up, it can tie the voluntary sector up and make it very difficult. So, yeah, I would say we need to communicate better and trust each other more, and start working more together. Collaborative working, I think collaborative communities, collaborative working, I think that's all
very
there.
strong with breakdown of the right issue of pain. Okay, Councillor Briefing, would you like to?
Yes, thank you, Chair, and thank you, Councillor Newland, for coming this evening. It's really appreciated, and your presentation. You've got a lot to left it, so I really appreciate that as well. My first question is about health checks for residents with learning disabilities. So as you know, there is something in place where doctors should be, making sure that people with learning disabilities are getting an annual health check. But I know that some of our doctors are kind of having the first check but not following up on the second. And I just wanted to ask, what are you doing to make sure all of our residents with learning disabilities are getting those checks and are getting the healthcare that they need?
Without wanting to back the question directly at Les, I would say I meet regularly with Les, and I would hope when we say are there any red flags that would come up.
Yes, partially, but it's really a health question. It's been an ongoing issue for Thurrock and to improve GPs in terms of health checks and money getting through. Up to the start of COVID, that improvement had increased year on year. But I have to say that since COVID, I'm not sure of what the situation is like everything else. We need to sort of switch our attention away. So,
yeah. So sorry, yeah, that's gone across the play, wasn't it? Yeah. So obviously last year, target. Their colleagues. We monitor the data on we are about now that's where there was a lot of income. More processes and check, so we really pushing to get back into last year. Absolutely.
I do realise that it is helpful learning disabilities.
Yeah,
so
absolutely.
that's why I
and that's what I was going to I was waiting for the end to say. There's always crossover, and this is what we've been talking about recently, isn't it? Of working, we work closely, don't get me wrong, but working more closely and really looking at those crossovers. So I've written it down, I'm sure Alan's written it down, or pick that up for sure.
Fantastic.
Before I ask my question, just to say that that issue has been around for so long. The very first meeting of the Health and Wellbeing Board, when it came to be, the issues that was raised there. It's so difficult to get all the parties that are involved in getting that right together and to actually say, but at least that things seem to be improved. Increasingly urgent because those people are in this.
Absolutely, and I agree. I think it's probably a sign of the times we've been in over the last few years of trying to juggle all those balls through COVID and now catch up as well. So we're very aware, just from looking at some of our figures, how the care packages around adults with learning difficulties have had to increase because they've lacked some preventative care there. So we're starting to get some statistics and analysis on that to share with you and to talk to you about. So I think it's a case of we're on it, but there's so many things to be picked up, but it's there.
The question I wanted to ask was, you mentioned about consulting people before decisions are made. I think with service users, it's actually likely that they are involved in the decision making. So how do you do that?
Consultation, and if I use Thurrock day centres, that was very controversial for some. I'll openly talk about that. I said we need to speak to every user of that service, and they were contacted. Some of it had to be by phone because we were still within COVID restrictions then. Most of them were seen in person, spoke to the carers. There's individual consultation and larger consultations where we need it, but it's vital. And if I had to just get up off my backside and go and visit and do it myself, then that's what I do.
Yeah, I think they should be individually paid. I'm sure he's able to access them.
Yeah.
Thanks again. I think I'd be remiss if I didn't talk about budget, and I know we spoke, you mentioned it for council last month, and obviously we all have a background in health and understand the pressures of budgets, but obviously there is a considerable overspend. We know why, and my question is, what impact do you think that's going to have on the service as a whole, and what are you going to do to try and, I guess, mitigate some of those pressures for your service, and are you concerned that that would have any impact on any of the service users?
We met with some mitigate them, yeah, where we kind of like, yeah, we understand we've got some pressures, but again, the statistics are coming in at the moment to really understand where those pressures are. Start looking at some of the external packages, like within some children's care, in adults care as well. There are some real hefty priced packages that maybe they do need to be that, and that's fine, but there might be things we can do. So that's where we're going to start looking. But yeah, we're very aware.
Yeah, I mean,
There'll be pressures, and the last thing I want is for services to go down. We want to.
I think that, yeah, I saw the pressures for this year are covered, but for next year and the year after, there's definitely, and I think it would be nice if we didn't kind of look ahead and kind of worry about what's going to happen to come.
Thankfully, I say that Ian and Joe, with their public health background, and they are so good with statistics. Ian's been burning the midnight oil because systems don't necessarily talk to each other, so he's getting data from here and data from there, and he's spending his nights putting that together for us. But we are starting to get a really good.
Just need to make sure, obviously, as you know, that you wouldn't ever kind of reduce anyone's package unnecessarily,
No,
or, you know, anyone's difference in care. We don't want to get any of those complaints.
No, that's the last thing. That's the last thing anybody around this table wants, isn't it? We definitely singing from the same hymn sheet on what we want for residents. How we can do it.
One question I had was actually based around the care package. Are we seeing a more integrated service provider where, so these packages are designed for each individual person? So we're covering every aspect, not that just if they get flats in different people.
That's what the transformation programs. That's what health and wellbeing teams are about. So I think you had the transformation paper last time come through. The piloted schemes, we know they work. We know it reduces hospitalisation by about threefold. Appointments with GPs by about sevenfold. But what it does for a resident is give them more control over their package, and it allows the team to upskill, talk together. It's joint working from Overarching, so that you can change that care package flexibly and quickly, rather than be tied up in the red tape that we talked about. For me, that's a real high priority. I've shared a story. I have a friend that has MND, and her package has to change sometimes very quickly, from last week being able to walk to the next week not being able to walk. And to go through that tick box exercise of when she needed to go into respite care of an hour and a half with a manager ticking off boxes to see if she fit the criteria to go into that respite care home. This isn't being thorough. I will say this is not thorough. I must stress that. To thinking, yes, she's going to be going, to being told, no, you're too high, you don't meet our criteria, to go through that again, to be told, yes, you meet the criteria, to end up in a respite care home that didn't have a hoist and couldn't lift her into a shower. So she went from home not being able to have a shower into respite for 6 weeks with not being able to have a shower. So I don't want that happening in Thurrock. When I told her about these health and wellbeing teams, she said, oh, please, I hope that we get them too. And we've had this conversation. They're vital to doing exactly what we're talking about here.
It was just when you, on your report before, independence.
Yes. Yes, absolutely, absolutely. Dignity is top priority. You need to be able to know that the person that's caring for you, I know it's a job, but you want a connection and to build a relationship over time so that you can trust them to do those things for you that you can't do for yourself with dignity. And as like my friend, at some point she's going to lose the power of speech. She needs people around her that already understand her and know she doesn't like tomatoes and know that, you know, she's allergic to this cream and not that one. It's vital.
Councillor Briefing.
Thank you very much, Chair. And again, Thank you for coming along tonight. Really, and trying to work with us, which is what I think I very much took from your statement and your presentation, is that no one of us has got the answer, and certainly no one of us budget either. If you don't work together. So you already mentioned the white paper, the health and social care bill that's been looked at, and the NHS long-term plan. Councillor Follow and I were sat on the meeting earlier on, and then I sat on the second meeting where buzzword is integration, but two people that were conjointly are not integrating with it. And I feel sometimes local authority and NHS are in that situation, and the silos that are trying to protect people actually then start to limit or damage their care. Yeah, the other thing that we spoke about is packaging and going forward. Do you feel there's room there to start looking at making investment in preventative education, so that we obviously are seeing longevity, living longer? Is that quality of life as they get older, which then starts to make demands on adult social care services? Do you think there's some work that's done? Well, education about looking after self, and quit smoking campaigns, the obesity campaigns, you know, and as we've seen before, a lot of the voluntary sector organisations that I've mentioned and together with Health Watch, you know, the Tai Chi classes that enable people to stay mobilised rather than be given money at any time. That those type of things. I think we did a lot with children about the obesity issue. I think, especially in this area where we have a lot of passion about COPD, air quality. We could get some education front loaded, go on.
I can tell you what I've seen, what I know is going on with your chicken, but that is part of the preventative care. So some of those drop-ins, they've got leaflets and information and can help inform people that way. I noticed that there's self-help ideas that you can take from the council website about if you're wanting to lose weight. And there's all these different options, from going to a slimming club, to going to a gym, to a boot camp, and they were offering 12 weeks free of charge so that you can get into the swing of it and educate. So there are programs like that going on. So I don't know if you're aware of more on that.
Yes, well, I could probably use the whole of the scrutiny.
No, please not.
So in the last 10 years, Thurrock has been on a journey moving things up towards making integrating with health at every opportunity. Our transformation program was years ahead. So, for example, we've got things like and it hasn't got an right. And we work with people fairly early on in their journey sometimes to connect them to so to help them to realise their evolution in good life, which is often not about clinically, often about a whole range of other things. We've also got as community-led support teams that are out there working. So the idea of that is that we make the services completely accessible. So we have social workers holding each other. They can sort out issues or about they can get that early and that attention. But ourselves and the Alliance in helping the sector are committed to pushing that. And attending it. So we have place-based strategy that's on the way. It should be ready within a month, and it's a really extensive document that sets out everything that we're trying to do in terms of more effective, because we talked earlier about budgets, and actually the only long-term way of managing budgets effectively and being with people earlier in the journey, that will prevent them from deteriorating. Yeah. But it goes beyond just things like obesity and smoking targets, because they will have a certain, that's a very good thing. But we know that yeah, people's behaviours will still continue to take risks, and what we need to be able to do is to work with people, give them kind of sense of purpose that they need to stop them making those sorts of decisions. Good example, very quickly, and Michael scheme works with some people who are really, really marginalised, really at the edge of their community. We've been able to encourage them to start small business of their own, to work with something that they have aspiration for, passion for, and the transformation of those people, particularly around mental health, has been amazing. Case studies about all of that in the strategy. As soon as it's out, I'm sure you'll be able to read it.
Very comprehensive answer. Okay, thank you for your
So I'll just be really quick.
Go on.
I just obviously agree with everything that's said in the point around mental health prevention and just setting up a service, services part of that intervention, really identifying the risk factors for psychosis. Honestly, intervention before people experience those kind of first episodes of intervention, massive evidence base around how effective that is. So we'll roll that out.
Thank you. Again, thank you, Councillor. And again, as I say, anyone who's involved in rolling out the step down. Thanks. It's ahead of everyone else. Thank you for your thoughts. Thank you. And you're free to go.
Thank you very much.
Don't run. Okay, so we're going back to item 6 in the Cqc Midland South Essex Foundation Trust Inspection Report. I'd like to introduce Hannah Coakley and Diane Sutter back to the committee, and ask them for an update that they can provide.
Hi there, thank you for inviting us back. I mean, I don't propose to go through the papers I've submitted. I did the presentation at the last meeting. I've enclosed the full CQC report here, but just to give a brief synopsis of the visit. So the CQC did visit the whole trust in July and August of last year. They visited ED at Southend Hospital, medicine at Basildon, maternity across all 3 sites, and surgery across all 3 sites. And the report was published at the beginning of December, and what you've got here is the report that I took to our board meeting. As you will see, the trust was rated requires improvement overall, with ratings for good, in caring and effective, and the rest requires improvement. I think it's important just to add, as Southend was the acquiring trust as part of the merger, that's why the tables look as they do. I've listed there some of the key highlights from the general services, and indeed some of the areas for improvement. I think it was pleasing to note that there was lots of positives around the leadership and caring, good for caring, and indeed the care that we provide for our patients. it was positive to see that the removal of the inadequate for maternity in Basildon was removed, and I think that's really due to all the hard work of all of the staff in that area. There was some outstanding practice that was noted, particularly in the ESDEC at Basildon, and keeping the COVID patients out of hospital. There were, of course, areas for improvement. I think it is positive to note there were no surprises there, and all of the areas of improvement we as a leadership team were aware of and had plans in place. I've also listed there some of the areas for improvement for maternity, because that's not just on the Basildon site, but across the 3 sites. And then finally, just in terms of next steps, we do have a CQC Improvement Plan, which is reported to our Quality Governance Committee, that being a subcommittee of the board, and that's being revamped to include all of the actions. And I think, just to note, there is a particular focus around making sure that any actions we take are sustainable moving forward. They're not just a tick box now, but it's in terms of ensuring that sustainability, not just in one particular area, but across the whole trust. So, Chairman, I'll pause there and happy to take questions. As I say, the report's there and there's quite a comprehensive summary. So happy to take questions.
Thank you for that. Yeah, one of the questions I had standing on here when I was going through the report that jumped out was, is there now a more robust procedure for prioritising women in triage?
Yes, there is. So there was a lot of work. We had the national safety team in from NHSI to support us around particularly maternity services, and so we've learned to been able to gain best practice from other trusts, and that's now being rolled out across both Broomfield and Southend sites as well. And there's evidence of good sustainability, which we monitor as part of our Section 31 report as well.
Brilliant. What sort of steps have you done to improve the cleaning side of the hospital? I know that's quite in depth on the report. So is that was that down to lack of staff, or was that just an oversight?
No, it wasn't an oversight. I think, of course, there were a number of challenges during COVID. Audits were being done. They were reduced for obvious reasons. That has now been picked back up. I think there were some issues around consistency and continuity of staff, again ensuring that sustainability of the standards that were being performed. But I think we are well on track now to ensuring sustainability of cleaning standards as well.
I'll go to Councillor Fish.
Yeah, just shocked at the amount of issues raised in this report. Really basic things like storing of medicines, time and time again. Lack of staff appraisals, so many different things. And the so then mentions as a positive that the trusts were aware of these issues. Plan. How can we be aware that things aren't being stored properly, hasn't been fixed already?
I do agree with the councillor. As I say, when we had the first meeting, that's what along with you, I was shocked that it kept getting repeated. Do you have a comment on that, please?
Yeah, no, I mean, I agree. I think there were clearly some own goals in this. There were some issues where things like checking of things, which we have seen as a repeated recurrence, not just with medicine storage, but other things. I think what we did during COVID was we did reduce the number of times that we had to check things, and that's continued. And it's an ongoing challenge where we have to ensure that checking is done. And it is a challenge for us. I'm not going to sit here and say it's fine. We will continue to ensure that those things are audited and monitored. And again, in terms of staff appraisals, we did reduce our trajectory, but the CQC monitor us on the national standard. But we do have our own internal trajectory, which we amended during COVID, recognising that actually these things were a challenge to achieve during the pandemic.
Have any other questions?
Really not happy with that answer.
I'm sorry, I didn't hear that.
I'm not happy with the answer. I'm involved in organisations that are successful, doing well and outstanding, rating out as outstanding. And to say there's a continuing problem with something which, you know, should be at the top, there should be, the ethos should be, these things are going to happen and everybody should be aware of how they're going to happen and how they're going to be sorted out. Shouldn't have to be.
Yeah, so the ethos is that as a leadership team, everyone is clear around what the trajectories are, what the performance targets are. Each divisions are held to account for these at each their monthly accountability meetings. So these are monitored by the leadership teams on a monthly basis. And that we have the clear trajectories to try and achieve those. There are priorities, of course, that we would rather our staff be caring for our patients than doing appraisals, but they are monitored and we've got clear trajectories to achieve them.
Do you know what, actually, I do agree with that. I do think it is an aim of firefighting. Also, I know there's also a certain amount of publicity that happened from the last HOS meeting that I know you had a chance to comment on. One of the things I said, I was disappointed with the report. And again, comeback was we put 40 staff in, we've employed 40 new staff. So, was that for maternity? Or was that throughout the hospital?
No, we employed 40 of our student midwives that were newly qualified into the maternity unit. So that was a very positive thing that we were able to retain our student midwives.
Right, okay. Just one of the comments before was that obviously the lack of staffing throughout the hospital, and a lot of this shortfall has been made up by doctors being brought in from other areas and from abroad to cover the gaps. What sort of percentage are we looking at on that?
I don't have the exact percentage now, but in terms of both nursing and medical cover, we took a report to our last board demonstrating our safe staffing levels for nursing and midwifery, and we did maintain safe staffing levels in almost every shift of January. So they are monitored on a daily basis.
I just wonder how in tune they are with your procedure guide of the equipment checking, the cleaning routine, with the triage system. Is there a period of training they go through before they're allowed to go straight into?
Yeah. Yeah, of course. Every new member of staff and indeed agency or locum staff undergo a induction period and an induction checklist, whether it's policies, where various things are in the departments, and that's signed off by the relevant departmental managers.
Okay, thank you. Does anyone else have any other questions? First of all, Councillor.
Just on the staffing levels there, you mentioned maternity. In the other departments, the ED department, we've got figures on that about the safe level of in those, and also for Basildon, the cath lab, the PPCI. But where am I finding this? That in surgery, in medical, where is that treated separately? How do I extrapolate the cath lab?
I can't quite hear all of the question, but in terms of staffing levels for the cath lab, did you say?
Not staffing levels, the performance rating. Does it come under surgery? But where would, if I wanted to look
Right,
at
yeah, no, the cath lab does come under medicine. It comes under medical core services, but they didn't actually review the cardiac cath lab as part of this CQC inspection. They didn't know on any of the sites.
Staffing levels was more around other departments such as ED.
All of those services they looked at maternity surge, those core services which I described at the beginning. They looked at staffing levels in those particular core services.
Thank you.
Yeah, hi. A couple of points from the Thurrock Coalition point of view. We were talking about this earlier. Obviously, some of the people we support are quite alarmed when they see a lot of requires improvement, and a big report like this is hard for people with learning disabilities to understand. One compliment that keeps coming through, though, is that people do feel well supported through your learning disability extra assistance that you give. We know of people in Southend and Basildon that is working very well for. So there was a plea to keep that going as it is, because it is working well for vulnerable people even during COVID times. But their overarching question was, what are you going to do to ensure that, given that the requires improvement is a downgrade under well-led, what will you do to ensure that you're going to be well-led going forwards? Yeah, no, and that's a very good question, and we obviously reviewed that as an executive team. Part of the challenge when the CQC came and inspected us, obviously, was that we had only just merged as an organisation, and we were unable, because of the pandemic and because of the merger, to demonstrate sustainability of all of the changes that had been made and were being made, continuing moving forward. So we would hope that if the CQC were to come in now and then, or on the next time they would visit, that we would be able to demonstrate that well-led leadership for the sustainability of the improvements that had been made.
Don't let me go again. You stole my final question. Sorry. Okay, does anyone else have any questions? No. Okay, thank you for attending again. I say I did ask most of my questions at our first meeting and got most of the questions out. So I do appreciate coming back for this evening. And you're free to leave. Thank you.
You're very welcome. Thank you.
Okay, so item 8. Can I ask Joe Hallman to present the item, please? It's the COVID update.
Yes, Chair, I'm just going to share my screen for the benefit of those online. And I believe those of you in the room have got a hard copy of the slides. So I'm going to go through the usual slide set that that the committee will be familiar with now, but the first thing to say is this is probably the last time that I can go through this particular slide set. With the removal of the restrictions and the cessation of COVID testing for the majority of people, we obviously won't be collecting this data at a national and indeed local level after the end of this month. So this may well be, yes, the last time I go through it with you. So going on to the first slide, looking at the current picture and how we compare with our neighbours, our current COVID positivity rate is 277 per 100,000. For a bit of context, back at the start of January, it was 2,275 per 100,000, so it's substantially lower than it was at the start of the year, but much higher than the 10 per 100,000 that we had last May. So we've got sort of intermediate levels at the moment. Our positivity rate, so that's the number of tests that test positive, are about 13% at the moment, down from about 40% at the start of January. And moving on to the epidemic curve, you can see that very big peak that we had in January with over 2,000 positive cases per 100,000. You can see it's fallen substantially since then, our positivity, our COVID rate, but we've still got sort of intermediate levels of COVID, and it's been somewhat up and down around this level, apart from the peak over the new year, since about July. So although the rate is going down, we still have a fair amount of COVID transmission within the community, which our positivity rate of 13% shows. So in the summer, that was down to say 1%. So we still have COVID circulating to some extent. And at the moment, the highest rates are seen in working age adults. This is quite a change from the picture that I showed you back in January, when the highest rates were, and indeed since September, the highest rates had been in this 10 to 19-year-old age group. I think given increasing rates of vaccination in that age group and the fact that so many of our young people have had COVID over the past few months, that rate has now fallen and hopefully will stay low. Rates are going down in all age groups, which is good news. They're just not going down as fast now in this working age adult group locally. This is the picture for bed occupancy in BTUH. You can see that we still have some beds occupied, but these are largely COVID oxygen beds and not ventilation beds, which is good news. But we still have, although rates are falling, a sort of residual number of people who are being hospitalised with COVID, which obviously says we are still getting some serious illness from COVID as well. So this is the vaccination data in Thurrock as of today. The rates of fully vaccinated individuals fall from the highest, from the over 80s. As we go down the age groups, the rate of fully vaccinated goes down as we go down those age groups. And for these rates have not increased much, I have to say, in the past couple of months, apart from the under 15s. Really, these are not moving now, these rates, very much at all. These are the rates of booster uptake, and again we see a similar pattern of very high uptake in the over 60s, and then it falls gradually as we go down the age groups. So this is the map of the distribution of COVID. So every unique postcode in Thurrock has had at least one case in the past 14 days. So you can see that that ongoing transmission is very widespread and diffuse across the borough. But whereas in January we would have had some very dark blue areas where there was very high rates of infection, we've got these light blue areas now showing that most areas have just fewer than 9 cases within the past 14 days. And we hope to start to see some white patches again on this map soon. We have 3 schools and colleges in live outbreak and 3 care homes, which again is much lower numbers than we have seen over the majority of the pandemic, and certainly lower rates than last term for school outbreaks. So just a little note about the Living with COVID guidance that the government issued on the 21st of February. The Living with COVID plan is structured around 4 principles, the first being living with COVID, so removing the restrictions and encouraging safer behaviours and personal responsibility. The second area is protecting people most vulnerable to COVID, so that's an ongoing focus on vaccination and deploying targeted testing. So for example, in care homes, that testing will remain. Maintaining resilience will involve some ongoing surveillance, contingency planning, and crucially for us, the ability to reintroduce key capabilities should we need to. And the fourth area is around securing innovation opportunities, which is more of a national programme and not particularly relevant to our local response. So we're doing some thinking within the council of what this means for us, and there are actions that we need to take in 3 broad areas really. So first of all, the public health COVID management response that Councillor Hewlin referred to earlier, and thank you for your very kind words on that, Councillor Hewlin, very much appreciated. What we're doing now is scaling down the response. We've stopped contact tracing, we're scaling back very much, but with an ability to scale back up should we, for example, get another highly transmissible variant later in the year. So we're doing that planning work at the moment, and we're also just working through what the guidance means for our local care homes, for example, and we'll be we're working with them still to make sure they are safe and supported, and we'll continue to support these high risk settings such as care homes through our public health response. We're looking at what this means for the council. So there's things around updating guidance for staff, that's things around sickness absence, around safe working practices, looking at how we scale down some of our communications and updates in particular, because we won't have that same level of data to be able to do that detailed updating that we've been doing, but also ensuring we've got contingency plans in place for social care surge should there be a need for that. And then there are issues for the wider health and care system that we need to consider, and these include infection prevention and control support for care homes, maintaining the system's ability to discharge from the acute sector, and an ongoing focus on vaccination. And just on that last point, so this is my last slide. I've got summary of the data that I've just shown you at the top, and our key priorities going forward are going to be focusing on vaccination. So we have had quite a bit of national support recently. We've had the National Surge Response Team in the borough over the past couple of weeks doing door knocking. They have given out thousands of leaflets in some of our geographical areas with lower uptake, and they've been going around knocking on doors, talking to people, seeing if they had any questions about vaccination, and inviting them to attend a local pop-up vaccination clinic that's been in place in local areas over the past few weeks. So that's been great. And we've also got some national funding to fund community vaccine champions for the next 6 months. So we have a programme, we've got some vaccine champions recruited now, and they are starting work imminently. We're going to be focusing on those lower uptake communities, those sort of geographies with lower uptake, and we know where they are. We've got a lot of analysis on that. Supporting pregnant women, because there has been quite a lot of confusion on safety for pregnant women, and also focusing on children and young people where we've got much lower levels of uptake, and there's potential, I think, to work with families and ensure they've got the information they need to make the decisions about vaccinating their children. The Vaccination Bus is going to be popping up in the borough over the next 8 weeks. So during the first week, it'll be at South Essex College and at IKEA Lakeside, and it'll be, popping up in various places after that. And we're looking at trying to maximise uptake among 5 to 11-year-olds during the school Easter holidays. So we'll be working with the vaccine champions and EPUT to try and coordinate some work around that. And that's it. Thank you, Chair.
Brilliant, Jo, thank you. I think you covered a lot of my questions in that last statement. It was around what we're doing to boost the vaccine uptake with the extra funding that's now being allocated, and where was the buses going to be, and how effective has the COVID champions been so far. I think you sort of just covered that really for me. One of the questions that I keep getting asked, and I don't know if anyone, maybe Mark, could help as well. With the drop in testing that we're now doing nationally, are we still be doing random testing for different variants in each community?
So I think there will still be genotyping and sequencing of samples that are obtained, but I don't think there is a plan to do random testing. There will be symptomatic testing happening where required for healthcare purposes. There will also be testing ongoing in care homes. So there will be PCR tests still going through the system. There just won't be as many of them. So there will be an ability to continue to sequence and genotype, but there won't be as many sequencing and genotyping, as much sequencing and genotyping being done. So we may not be able to identify those variants as rapidly as we would have done otherwise, I suspect.
Well, on the subject of COVID, well, I don't know if you can actually answer this question at all. As a councillor, what is this chairperson, I'm getting a lot of questions by residents why they still can't visit or have to have a timetable slot to visit, and we're told there's no restrictions nationally. And I'm getting bombarded with some really heartbreaking stories. I don't know if there's anything.
I'm wondering whether we've got Hannah from the hospital on the call. So I'm wondering whether.
Hi. I think it's about visiting, but I'm really sorry. I'm really struggling to hear some of what's being said.
Thank you, Anna. Yeah, as I say, we're getting a lot of questions from people that are still unable to see their loved ones in visiting, apart from having scheduled visit appointments and shorter appointment times. Again, it's very heartbreaking for people. I just wonder,
Yeah, I know.
especially when national restrictions have been dropped.
Yeah, so so I know that national restrictions, but obviously still within the healthcare environment, there are restrictions around visiting. We've obviously recently, as you say, reduced the no visitor policy, and people can book and have one visitor, as you say. We do use discretion. So obviously there are exceptional circumstances where we absolutely do use discretion, obviously in critical care, palliative care situations. And we, just like you, are really hoping that that guidance will be relaxed as soon as possible, because we know how difficult it is, both for patients and for their families, not being able to. We do have which isn't the same as visiting face to face, but we do have a facility where people can send notes and letters and communications via the communications team to their relatives if they want to do that, and that's been a really well received initiative. But as we say, we're hoping that in the next couple of weeks we'll get some updated guidance on infection control in terms of some of the pathways that we have, and also have the ability to restrict to further relax visiting requirements, because we absolutely know and understand how important that is to everybody.
Thank you. It's also the same for AME attendance, where people are not allowed to be accompanied to AME.
Again, that is, I mean, generally yes, but there are exceptions depending on the environment. But yeah, at the moment, it's still pretty strict, I'm afraid, which again is not ideal for patients, for their relatives, and actually for staff as well, because we know that we have a number of anxious patients in the ED. We do try and use discretion where appropriate, but as I said, unfortunately, that is still national guidance.
Yeah, it is sad, because I do know that as your security staff, they've been really helpful with the patient being left unattended, or not having no one else with them, and they've gone above and beyond with
Yeah, thank you for saying that, because actually the security team has been phenomenal, and it's really so difficult, isn't it, having to make judgments about letting people see their parents. So thank you for that feedback. I'll certainly give that feedback as well.
Councillor Fish.
At the moment, we seem to be getting about between 40,000 and 50,000 cases a day still. So something that's obviously still an issue, and yet it's need to be kind of scaled down. So talks here about the ability to reintroduce key capabilities in an emergency in a situation where you have 40,000 to 50,000 cases a day, things being scaled down. You can see variants rising quite regularly in that situation. How quickly can those key capabilities be reintroduced?
I think the question was, how quickly can we reintroduce capabilities should we get another variant that is highly transmissible?
Even highly transmissible and more severe.
Yeah.
Or more severe.
So there's a number of elements to this. There's the national element and the local element. So at the moment, the Department of Health and the UK Health Security Agency are dismantling a lot of the national infrastructure, so the data reporting systems, etc., that we have relied on to be able to, present the data that I've presented to you this evening. That won't be operational, but what we need to do as directors of public health, and I was in a meeting with them earlier this afternoon, is get assurances from them that we will be able to step that up again should we need to. In terms of our local response, a lot of we've learned a lot during the past 2 years, and so we have now a lot more expertise in outbreak management within the local authority public health team than we had before. We've created, so we went through a restructure process as part of the council's target operating model work, but what we did as part of that restructure, we created a new permanent health protection lead role. So the public health team didn't used to have a health protection lead role other than our consultants in public health, but so we now have dedicated capacity, and we've appointed someone who's been working with us for the past 2 years on COVID. So we've got that organisational memory. We've worked on the plans to make sure that we've got plans in place to step up the response really quickly again if we have to. And we can do that because our contact tracing has been led by two different groups of staff. Firstly, staff that were usually pre-COVID library surge staff, so they are staff contracted to work part-time with the council, so they will continue to be associated with the council, and we'll be able to co-opt them, I think, back into the response. They were our senior contact tracers, and then the rest of our contract tracers were agency workers, but we've got now a bank of agency workers that have been working with us sort of on and off for quite a long period of time. So our first call will be to go back to those agency workers and see if they can come back and work with us, because they would be able to hit the ground running. So I actually think, given that if we have the capability for the data to start flowing again from the national team, so the test and trace data essentially from the testing coming down locally, we could actually step this up very quickly again.
Thank you.
Sorry, Jake, just on that, you did allude to in your presentation about the like the effects of long COVID and sickness within the workplace. On the early report, we say that we're staffed. That's on paper, but I know from my own experience, I've got four lines out of Thurrock that are personnel assigned to them, but they're not physically at work. So, although the sensible issue saying about us being reactive, so we might look on paper as if staff in there to cope with the new variant or new surge in acute illness. How confident are we that we have got those human resources to man those beds?
I'm sorry, I didn't really catch that.
What levels of staff sickness, long COVID, absenteeism, how would that affect a reaction to a more acute variant or?
Oh, yeah, okay. So as part of the Living with COVID guidance that I mentioned, one of the things that is required of the council is to have staffing contingency plans in place for social care for that very eventuality. So that is something that we need to look at and make sure we've got in place. We do, however, in Thurrock have very high vaccination rates among our social care and our care home staff. You know, whether that how protective that would be against a future variant is something we don't know, but we do know that vaccine raised immunity does give some protection against a range of variants. So I think we're in a reasonably good place in terms of that vaccination uptake and in terms of our forward planning that we're doing. At the moment, we've got very low levels of sickness absence due to COVID, and it's falling in line with the local sort of infection rates.
I've got one question. So no.
Joe, this is a question about working in the community. People are very clear that people in care homes are having tests daily and staff in care homes are being tested daily, but there's a bit of confusion about social care and home care. And are home care staff meant to be testing daily as well?
So I think all frontline social care staff would be covered. So the latest guidance I've seen from Cqc implies that all social care staff, so this would include children's social care as well, should be subject to the same guidance. So for care homes, it will be that there will be monthly, I think, PCR testing for residents, and then the more regular LFD testing. The guidance is, there's certain contradictions in the guidance and statements that aren't exactly pinned down. So what we're trying to do at the moment is just pin some of that down, and then we will send out guidance to care homes and to others who need it. There is a bit of ambiguity in some of this around social care, to be fair.
I think that's what they're picking up on, Joe. So there was some nerves. That would be really good to get some guidance from your team, just so that people are really clear what they're supposed to be doing. Because one of the issues is the staff are worried about having to pay for the tests. So that's causing a bit of anxiety. So it kind of needs to be a strategy basically.
Yeah, so my understanding is that tests will be provided for social care staff. What I'm not clear on is exactly how that is going to work yet. But yeah, if staff are required to test, I don't think they should be required to pay for it. Yeah.
Thank you, Joe. Okay, moving on. Yes, Joe, you're free to go if you want to.
Great, thank you very much, Chair. Thanks. Bye-bye.
Okay, item 8. So I've just done that, sorry. Item 9. Progress report on integrated medicine programs. Can I ask Mark to present? Or is it going to be...
Yes. Thank you, Chair. So we have got some slides.
May I just help just to start us off, because I've got some more recent information than the stuff in Mark's slides. Would it be helpful if I just preview what Mark's going to take us through?
Yeah, if that's okay, Mark, if it's more up-to-date information, that's fantastic.
Thank you so much, Chair. And may I begin by thanking Councillor Mays for alerting me to the fact that we needed to keep on top of this, and we needed to get things right and nailed down in every last particular. Mark's slides highlight the fact that it's a piece of work in progress still at the moment, and so I'm grateful for that. And also very grateful to Councillor Holden, who keeps very close to all matters affecting the integrated care system and our system. And I have been briefing him, as I've been trying to brief Councillor Mays, on the ongoing discussions. So in recent weeks, officers and colleagues in finance departments have rehearsed and explored a range of specific solutions to particular aspects of a complicated building scheme. They've gone through a lot of detail between finance colleagues, and I'd like to now just report the approach that we're adopting and the progress that we've been making. We have on the screens my colleague Dawn Scrapefield, who is the finance director for our system, and Mark is going to paint in the local bits.
Well, can we just wait a second and see what's going on here?
Someone's going to share the screen, so
Is it Joe?
So Dawn Scrapefield, as we look, is the lady in the centre of that picture waving, and Mark can do the local bits. Mine is the overview, Chair. What we've been exploring in the last week is the scope for 2 initiatives that can address the remaining aspects of the scheme that we're trying to nail down. I wrote to Councillor Mays with a letter outlining some of the horrendous detail around this sort of thing, but the essence of it was that when the case was last submitted to the finance leaders group that there were a lot of complexities that still needed to come together. These were associated with the fact that we're working with a site that is contaminated, together in an integrated building, but we didn't have a fully documented operational policy that
Well done. Thank you, Andrew. Sorry about that. Hello.
So, Chair, I can do a human impression of the internet freeze
Yeah.
and pick up exactly from where I left off.
Thank you.
So I was just saying that I had shared with Councillor Moyes some ideas that we were exploring to get us across the line. Those ideas fall into two camps, really. One is technical stuff, and that's technical things like the period over which a scheme is costed and charged against. They go to all the intricacies of discounted cash flow and things like that. You can sometimes do 40 years in the NHS. I believe the more common standard in councils is towards 60 years. That affects essentially the monthly rental charges on different things. It's like a mortgage. If you have a longer term, the repayments are lower. So we were exploring things like that. The other area that I picked up, alerted by Councillor May's letter to me, was that there were concern about the burden of design fees. And for all the reasons that I highlighted at the beginning, we're working with a difficult site that has abnormal costs associated with it, some of which are related to our shared aspirations around sustainability and the green agenda. So I have been looking at ways in which the NHS could address those concerns about the costs that the council has incurred and assist with them through funding that comes in the NHS around sustainability and carbon net zero and all those sorts of things. The problem is that we're not quite at break even, but we were able to get Purfleet through the System Finance Leaders group only last month, I think, when there was a slight difference. But we were able to offer a very clear and specific rationale for why that scheme couldn't quite meet what the NHS would say would be a normal test. So we're closing the gap. We've got a very clear and shared rationale. But what we have to do now is to jointly keep a very close eye on value engineering the scheme, as the jargon has it. And that means being very clear together about who's in what room and how things are financed and all of that. Because we not only want to get to the point where Dawn, my colleague, can take the outline business case through her group, but we want to get beyond outline business case. We want spades in the ground and bricks going on brick. So we're all committed to making that happen as quickly as possible, because we want to get the right results for residents. And ultimately, it's the NHS executive, not you nor we, that determine whether or not public finance tests have been met. The other thing that I put in the note that I sent Councillor Mays is that I have offered the services of a very experienced and capable programme manager, so that you would have somebody in situ here as part of the programme board who could act on my behalf at all times and make sure that all NHS partners had coordinated their own separate bits of the scheme and therefore accounted to Dawn for the arithmetic of how everything added up, not just the bits that apply to their own organisation. So I apologise for a long and complicated explanation, but in generic terms, that's where we're up to, and we're closing the gap all of the time and heading towards Dawn's committee as fast as possible. I don't know whether Dawn can sort of confirm my layman's version of those events, but she's been very close and helpful.
If you go to Chris May, so this is obviously a very fluid motion. And it sounds how do you feel about the way that things are going? The offer there was putting something in situ. Plus, take up some of the problems we've had with not always the communication going on and update. You feel that's an essential position?
Sorry, excuse me, Chair. We haven't had the full presentation from all the officers
No,
present.
but
Can I
we-
ask before the internet cuts out that we get the full presentation
You will
before
get a
getting
presentation.
Councillor May's
Covering
views
all
on where we are?
So,
Because it's not part of the presentation.
Just to say a big thank you to Mac and his team for pushing this forward, because actually I think we've had previous meetings, lots of previous meetings, and we're trying to just get this over the line to the outline business case now, which obviously let's get to the full business case. We're not quite there as said, but I believe it's just a case of possibilities and the eyes now, and hopefully was hoping to have the finalised stuff today. And obviously I can't go into details of what fully was discussed because it hasn't been agreed yet. So during those. Thank you very much.
both of them. Vice Chair,
I got the presentation from the officers present, Chair.
yes, Mike mentioned Councillor Mays. I was listening, Councillor Mays come back in. The information is updated and superseded from what is in the presentation.
Not
Unless you wanted to add.
what the Councillor May said was that you didn't have any more detail.
Mark Tex, would you like to carry on, please?
Okay, so we've got a presentation which covers all four of the IMC. Obviously, from the discussion we just had, we won't go through any of the Tilbury slides because the information has now been updated around where we are with that. But I'm going to invite Martin and Carmel to present on the current IMC. Then Kerry will give us an update in relation to perfect ABC. We'll skip over the Tilbury slides, and then I'll ask Paul to give us an update in relation to Grays. And then Hannah's going to give us a bit of an update on the community diagnostic programme, which has potential to kind of align with what we're doing with the integrated medical centre. So I'll ask the presenters to be relatively brief so I have time for discussions, and I will hand over to Martin.
We have 30 minutes.
Martin, did you hear that?
I did, yeah. Is someone going to put the presentation on the screen, or do you have it to hand?
Yep, we have it at hand.
Thank you. Can I have the next slide, please, Carmel? So that's just the title slide there of the development in Corringham. It's a two-storey building, around 1,200 square metres. It incorporates multi-purpose clinical rooms and space for 2 GP practices. We've also incorporated in the design a range of group spaces that can be flexible enough to accommodate larger groups or individual groups into 2 or 3 sections. We've also got hookup facilities for mobile screening units, conscious that services from other organisations in the NHS will be keen to use this facility. Next slide, please, Carmel. That's the base area for where the development is. At the front entrance to the community centre, which is part of on the same footprint. We then enter the site with parking to the left, and the Ground Jam School is beyond that boundary, and then we come into the L-shaped building with the front facade on the soles. And next slide, please, Carmel. And then we come into the ground floor. Through the entrance, you'll see the waiting area and reception with clinic rooms around the perimeter of the building, which gives a bit more light into those areas. And then you'll see to the left of that is the group space with the 3 rooms that are interconnecting with soundproof doors. So that space is pretty flexible for whatever size group we need to fit in there. And next slide, please, Carmel. And then the upper floor is largely non-clinical space with hot desks, which teams from all across all the agencies were able to drop in and connect up and work from that locality. So we see it as a hub for Corringham. There'll also be facilities for sharing if people choose to cycle into a facility, given that the travel is going to be one of the key issues really in using this facility. Next slide, please, Carmel. Then we've got a range of photos there of some of the team which visited a few weeks ago, largely from Nelft. And the next suite are the external areas around the facility. You see it's tarmac road. One of the interesting parts which we could see at the front of the slide in the bottom corner is we've had some planting and some greenery put in place, and that was done by the children of the Graham James School. They had a real fun afternoon engaging with our contract team there, planting some border shrubs. So we've been keen to engage with the school throughout the development, and it's been quite a pleasure to work with them. Next slide, please, Carmel. And then the internal fit out, they're quite small pictures, but you can see it's a range of spaces from the clinical to open spaces. It's quite light and airy and gives that modern feel to modern health facilities, replacing some of those buildings which predate the NHS. So we're pleased with having such a modern facility available to us. It's such a key area of the services we deliver.
Thank you, Martin. Hi, good morning, good afternoon, good evening even. So starting from the bottom left-hand side, it was just a sort of roadmap, I guess, or the pathway of the plan that we're going through. So in October last year, we started to develop the mobilisation plan for Corringham with the hope that it would be operational by spring. During that time, subgroups were identified, so information communication technology, comms, engagement, finance, operations, and part of that was looking at reception and the functions of the building as well as the standard operating procedure. Estates and design and human resources and workforce were also part of those subgroups. They were all identified as having leads, and those leads have been meeting throughout that time to ensure that we're looking at all of those areas and continuing to work together as partners around ensuring that we stay on track. In December, there was an agreement around having a reception function within the building, lots of conversation, lots of discussion and looking at what we needed it for and how it would work, as well as thinking about the building manager. And there was ongoing meetings around how the services will be delivered and what services will be delivered. So within January this year, Corringham identified that they would be specialists within that building with regards to diabetes and cardiovascular disease pathways. And as in December, the services identified the utilisation of how that building would be used and how the services would use it, how the rooms would be booked, etc. Furniture was identified as well as the equipment that would be needed within the building, and unfortunately we were notified at that point of the delay with regards to the opening of the building, mainly as Mac had said, due to IT. So BT, we're working very closely to try and get a date finalised with them. February, ongoing discussions around finance, around how the hot desking areas will work, lease arrangements and travel plan, also thinking about parking and how the principles of parking would work there, including Parking Eye, which is a payment scheme, and ongoing work on the standard operating procedures. And final sort of amendments, I guess, to the building were identified at that point. The plan for March is that we're still hopeful that the building will be handed over in March. It's nearly ready, I believe, so there was a date early March for that to be handed over. There are some further planned workshops with community voluntary sector and third sector, identifying some workshops around how the reception will work, and there's been some planned visits, so there's some visits booked, I believe, on the 14th of March. And the last part on here is about sort of staff consultations, so those teams that are going to be moving in into the building and consulting with those teams. So on this slide, apologies, I've tried to make it bigger, but it's taken the top part out, looking at how the the principles of the integrated medical centres. So these principles are, have been identified throughout, and they include, you know, having a single locality model, getting it right first time. I'm aware of time, so I won't go through them all. Having faster access to diagnostics, I think, has been a really key one. Reduce waiting times, and having a one-stop shop approach for people to be able to come in and see lots of people all at one time, or see one person, but having expertise and access to others. And the hope is reducing referrals to secondary care services by getting in early as well. So the key themes reflected also within the service model include, as I've mentioned, diabetes and cardiovascular disease within the long-term conditions, access to outpatient clinics such as pelvic therapies and community midwifery, and diagnostics such as phlebotomy, ultrasound, and AAA screening, which I had to look up myself, which is abdominal aortic aneurysm, I hope. So also adult mental health services, adult community services, sexual health services, primary care, adult social care, children and young people services, and lifestyle and wellbeing, and all of our other community services that would be within there. And this next slide just sort of breaks down the actual teams. So the teams that are locally being delivered, that will be working either directly within Corringham or will be linking into Corringham. So they cover a lot of the NELF teams that are all on the left-hand side, including both adults and children's services. And then the right-hand side are the partner agencies as well. So from ePut, Thurrock Mind, Inclusion Thurrock, phlebotomy, so all of the MSc NHS Foundation Trust services as well that we've mentioned. And down the bottom right is the community voluntary sector and third sector. So I'll just move on to the next slide and hand over to Kerry.
Thanks, Carmel. Good afternoon, everybody. So just a quick run through from where we are for Purfleet-on-Thames IEMC. We've done a lot of work since December on the review of the business case, amending that in there to make that much more specific to Purfleet, and also to make sure we are meeting all the criteria of the Green Book process. We've got a lot more of detail in there now of the non-financial benefits that the service will bring and the building will bring, and also we've done a lot more work on the service modelling. What we've also done to look at affordability is a slight redesign of the facility. So that's now been reduced in size by about 190 square metres. However, this still provides significant capacity for planned growth, and there is flexibility in the design to increase the clinical or other patient-facing services space in the future. So as Max said already today, the SFLG have supported the outline business case on the basis of those revised plans and a revised affordability. The OBC will now progress through the sign-off process of each of the partner organisations. The OBC now sets out plans for a building of 1,814 square metres. So that's reduced, as I said earlier, based to a redesign. This does still contain space for GP, PCN, out of hospital, community mental health, council run and voluntary services. And it's also designed to enable use by the community to support local health and wellbeing initiatives. The target opening date remains in the financial year 24-25, and we are still on track to submit the outline business case to NHS England for support by the end of March. Hopefully, once we've got support, we'll be able to then move on to the full business case process, which is a much more technical, detailed stage. And once that's completed, we'll be able to start with delivery of the project. And next slide, please, Carmel. I've just included a couple of slides here to show the design of the site. So as you can see on the left, that is the ground floor. So it's almost a little bit of an upside down building. That ground floor will include hot desking space and back office space. There is minor surgery suite within this facility. There's some children's services space and mental health space. On the first floor, to the right hand side of the first floor, is mainly GP. So that would be the GP practice. And then to the right-hand side, the majority of those clinical rooms are currently based for NELF services. There's also a room just off of the waiting room that will be used by the council for drop-in and other services, so completely accessible by the public. And there is, as you can see, some really nice outside space that we'll be working with some of the community groups to design and maintain that facility. I'll hand over now, I think it's to Rahul for Grace.
Thank you, Kerry. So with the Grays IMC, I think the Thurrock Hospital has been identified as the site for the Grays IMC. The premises is owned by by EPUT, and both NELFT and EPUT are delivering services as we speak at the moment. We appointed ARCUS, the healthcare planners, to review the existing Thurrock Community Hospital and looking at the potential use of that site in terms of development of the IMC. The review concluded, I think, early this year, and made several recommendations, and it confirmed that it is an adequate space for housing various services, i.e. A potential for development of a community diagnostic centre, also moving of or decanting of the OC services, as well as potential for primary care services to be relocated from the existing premises. So I think the review is being discussed at our IMC program board, as well as at the Grays IMC program board later, I think next week actually. So now the work is underway to confirm the exact space needed for various services and again, ARCUS is now going to be looking at developing a master plan for this site. If we can go to the next slide, actually. So the office had also been asked to do a further work on doing an options appraisal for the primary care and PCN services. The appraisal will look at space request or requirement for both a primary care and PCN services, produce a long list of site options, and also a high-level schedule of accommodations, the construction costs, and the proposed next steps and recommendations. I think the work is meant to complete by the end of this month, following which it will be then reported back into the Grays IMC program board in terms of the options appraisal, or in terms of different options for the primary care presence within the Grays IMC. I'll hand over to Hannah to talk about the CDC.
Thank you very much. Thanks, Rahul. Actually, we did a councillors briefing this afternoon, so some people will have heard this previously, but as you'll be aware, there is a national initiative now on community diagnostic centres. So that is a 3-year programme of capital investment, really focusing on trying to separate out elective and emergency support services, both in terms of delivering surgical centres, but also diagnostics as well. This is a nationally funded programme, and obviously looking at a combination of sort of hubs and spokes, new sort of one-stop shops, really for tests and checks, and looking to link with the rapid diagnostic centres that you'll have heard about in relation to cancer services. So the process is really just started. And MSE system partners working collaboratively to decide the best locations of those centres. Clearly, there is opportunity for an IMC to be one of those, but it's also a process that will be led across the ICS, and we have to look at the whole geography. So that's the process that we're about to embark on now. As I've said, it's obviously about trying to separate out the elective and emergency flows so that we get the emergency diagnostics and services delivered in the acute units, and providing opportunities and areas for patients to be treated outside of hospital, both from a diagnostic perspective and elective over time. So the national process being established at the moment. So this is our first opportunity to come and talk to Overview and Scrutiny and Wellbeing boards about what's going on, and we'll keep you updated as we go along. The MSC board, as the slide says, is just being set up at the moment as part of the ICS governance arrangements. That will be led by the ICS, but obviously the trust will have a really important role in that, and we'll be providing routine updates about that as we go along. Clearly, this is the capital funding. There's obviously the revenue funding, and as we had a conversation about earlier today, there's also the issues of how we staff both of those centres, but a really important initiative. And importantly, we want to align that with the IMC processes, and it's not going to be taking diagnostic services away from the ICs, absolutely not, but this is about potentially enhancing the diagnostic services within MSC. So exciting opportunity, and we'll keep you updated.
Back to you for your question.
Thank you, Mark. Thank you, your team. Very good presentation. But I don't know where to start. Okay, first of all, current IMC. I don't know if I missed it, the 50 hot lists that have been put in there. Is that an addition that's been in there?
No, it's very always part of the original.
I don't know how I missed it. I think it's because we didn't have the floor level planes. So I visited the site, had a walk around. What I have noticed is again, with tightness in parking, there is still more optional. Haven't got the travel plan, we've got some travel plan.
Could I bring Martin in? Could you just unpack a little bit about the work that's been going into in relation to the travel plan and the parking corridor?
Yeah, of course. So in terms of the parking, there is, if we take the parking first, there'll be controlled parking on site. We don't intend to charge anyone to park on the facility, but it'll be controlled by systems, something like Parking Eye, where people will have their staff will have their vehicles registered, and anyone who uses the facility just registers their vehicle when they come onto site. There's still some negotiation to be done how parking will be managed. We have undertaken a travel plan, which is in need of a bit of review. So we've looked at alternatives to parking on the Corringham Integrated Medical Centre site, and where we could use alternative facilities. Looked at green travel, people using cycles, and that's why we've included cycle showers, and then looked at those bus routes. That was done back in July 2021. Now that the building is finished and we've had far more discussion throughout the sector and the locality, we need to just revisit that travel plan, which was approved initially as part of the planning.
Mark, as you know, it wasn't approved, so they're coming in front of anyone from the council at all. So when you stick 50 hot seats in now, there's a potential over 50 staff plus all the patients and all those staff that are working with them in one building. You've got a massive problem with where you're going to put parking.
I think probably the question better addressed back to Martin in terms of the kind of process of the approval of the travel plan and where it's gone within the...
So the travel plan was, sorry.
Travel plan, we had notification that the travel plan was pulled back in 2021, was withdrawn. We went out to press before it came in front of the council.
Okay, my mistake then. So we need to review that travel plan and then resubmit it.
Yeah, also where that now we've moved the IMC, obviously it's in Corringham, and the potential of a doctor's practice that may be going, we know people from Fobbing and Lancashire will have no opportunity to get to there because the bus route is only like once an hour. Are you looking at putting on a bus service, travel service for people to be able to access the medical centre?
It's not something we've done before, but it's certainly something we would investigate. Now that's been brought to the table, but it's not something we've done in other areas of our organisation. We've got similar issues, but it's something we would have to look at to make sure the building's accessible.
Anyone else have any questions on the comment?
Yeah, when the Corringham Centre's up and running, hopefully it's been proved successful. Is there any capacity there? If other services relevant to health and wellbeing want to take advantage of the site, I even actually come to you as well?
Sorry, I missed the last part of that question around capacity.
Yeah, so if there's sufficient capacity there, once it becomes successful, if other health and wellbeing organisations want to take advantage of the success of the site, is there the ability to look at whether or not you could derive an income from the use any spare capacity on the site?
It's certainly something again we would look at. We would probably review after the first 3 months of opening, see how clinics have mobilised. But there is that group space. You know, we're able to use the facility part of the weekend, so we would certainly want to make sure the facility is used to its full potential.
Yeah, I mean, it possibly might be 9 months into it being open or a year into it being open.
Yeah.
Find that there's sufficient capacity for someone to move on site that's relevant on a permanent basis, part of the site to deliver a service there. Is that an option that you can look into, which will also help fund the centre itself as well?
Yeah, it's certainly something we will look into, and we do it in other parts of organisation in Nelft where appropriate. There's certainly anything that contributes to health, we would certainly be interested in making that space available.
I think the ethos behind the integrated medical centres was that it was about integrated care and prevention and providing a space where we could look at the whole person and opportunity to have health and social care and third sector within one site. So that's absolutely the ethos of the space. And there, as Martin said, there is a number of quite large kind of group spaces that will be available for that. Obviously, we are trying to kind of maximise the utilisation of the space. So it is, as we're kind of going into the opening, kind of fully booked, kind of like Monday to Friday. There is space available weekends and evenings. The way the building has been designed is open up some of that group space without it impacting on some of the clinical areas. So the design of the building has been absolutely with that in mind. And having the kind of review processes around the utilisation of the building kind of built in regular intervals. So we're conscious that we're starting off with a plan around relocating services, bringing services together, but it will evolve over time. And that's a kind of part of the hot desking is bringing the clinicians together to be able to kind of relationships and think about how that integration can work and develop and flourish. So we know that we don't have all of the answers in, but I think we're creating the space for those kind of those discussions, relationships to build and new processes so we can learn and adapt.
I think, you know, for me, this planning, reading through the services that we're going to be providing, was such a positive experience. And I think, as you know, the part of mine is about trying to get mental health support in the centre of every community that we live in. And for the services that you provide from here, it's exciting. I know my saying national about the travel plan, but I've been, man, this is coming so close. I'm excited by it, and the readiness is excited by it. And unfortunately, my folks as well then. And I only shipped in the road. It's a nice sunny day tonight there. So, but yeah, it is exciting. And moving on to Councillor Briefing.
Thank you, Chair. And first of all, just a huge thank you to everyone obviously online for coming and presenting in detail on the thematic here this evening. I really appreciate it. And a huge thanks to Mark, Ian Wake, and all of the team for kind of continuing to push forward. I know a very complicated, complex and you know, very innovative set of projects. So, you know, when I ask my next questions, it is done out of a passion for these projects. Obviously, you know, as councillors, many of us have been involved for many years. So, you know, we very much want to see these be a success, and these points kind of come from a good place and a passionate place. I think my first question, and I have many, Chair, just so you're aware. I think if I just make a general point and then go on to the details.
Councillor Holloway, I would say we do have to leave by.
Right. We just spent 10 minutes talking about Corringham, and now no one else in the committee has had a chance to speak, and we only have 5 minutes.
Questions.
We've had 25 minutes on this item. Okay. Better speak quickly then. So there are wonderful capital projects happening all across Mid and South Essex. I was just on the call today when we were hearing about some kind of fantastic work at the front of Basildon Hospital, new roundabouts at Bloomfield, all of these wonderful things. I think my first concern is that it appears, and how I feel, is that the integrated medical centres have been chipped away at somewhat, and obviously the reduction in Purfleet, the square footage, the issues in Tilbury that have to be readjusted, and in Grays, I mean, we haven't even had a look at the site. I think I'm concerned, and I feel that Thurrock residents and Thurrock health isn't being considered. We're talking very much about affordability, but the focus isn't really on patient care. And we have a hospital closing, and these medical centres were very much set up and established as a replacement for the hospitals. And I'm concerned how the services in Orsett are practically going to fit in 4 medical centres. I'll keep talking because I've only got a couple of minutes and need to ask a few questions. About Tilbury, first off, what do we mean by a break-even position? So I'd like to know what that means specifically. What was the decision with regards to, bear in mind, I think we paid for the design, who's going to kind of cover the cost of that? How did we get to this stage, which very much feels 11th hour stage with Tilbury? We must have known the land we were building on. It very much feels like we are changing the goalposts somewhat on that. And so that's on Tilbury. On Purfleet, I can't believe that reduction in square footage has been had, and that we can still kind of accommodate all of the services needed. I'm worried about the CDC from the Grays point of view, site point of view. Again, sorry, we're having discussions to see if services fit at the Grays site. We had a tour of the site many years ago, and we were told what would fit and what wasn't. Are we now going to try and squeeze a CDC on there, or do we not get a brand new CDC? Are we going to again be somewhat shortchanged, and are we going to have that kind of into an IMC as well? I don't really understand how any of this is going to fit. I've got more questions, but bearing in mind we've only got a couple of minutes, Chair.
Yeah,
I will ask
I've just checked
for the response.
I've just checked with Jenny Shade. We do.
That should have been a consideration when chairing, shouldn't it have been? So if I could just get some response.
Unfortunately, Vice Chair, as you know, we had technical problems. That's fault of yours, Chair.
It's your chairing that's the issue.
Thank you.
Your mistime chairing.
Could I just let
Shall I have a go very rapidly?
Yes, we do have like 2 minutes.
My colleague Dawn will be able to help with the notion of chipping away. I have no sense of that, in all honesty. That isn't something where capital projects elsewhere have chipped away at anything. That's not no part of my sense, but Dawn will have a better view of that. On your specifics, Tilbury break-even position, what break-even generally means is that the replacement facilities will cost no more in revenue terms than the provision it replaces. That's what the phrase means. Dawn will correct me if I'm wrong. In terms of the design costs and how they can spiral on a site like this, and who covers that cost, that is something that I'm conscious of, and I'm looking at ways in which the NHS can positively contribute to that and alleviate costs that the council would otherwise carry. A feature of this project. That is one of the, as you put it, last minute, 11th hour things that I have come to appreciate and sought to address. In terms of the 11th hour, yes, we are working intensely to try to get this across the line. It's not so much moving goalposts. What has happened is that you only get all the numbers in at the end of the project as everything comes together, and we're trying to get those aligned. Dawn is more expert than me in particulars, but those would be the generalities as I honestly understand them. Chair, Dawn may be able to just refine those points.
Yeah, that's fine. Dawn?
Yeah, no problem. Thank you very much and good evening. So just in terms of the point about the closing the gap, I think it's fair to say that Mike and Mark Barker, who has been liaising from the CCG, have been working through with colleagues such as Kerry to try and get a position that means that for our population we can afford the most and best possible facilities. That, unfortunately, when we met at SFLG a couple of weeks ago, there were still a number of questions outstanding. And what's been happening since then is obviously trying to refine that. It became apparent that the difference in terms of planning on the valuation, for example, the 40 years in the council terms and the 60 years of the NHS, was a way that we could manage a cost differently, but not compromise on some of the considerations. That being said, as Mac has already outlined, actually there are still a number of considerations, not least of all parking at Tilbury, that is still an area that needs to be looked at. So I think both parties, we're all as partners trying to get a resolution on this. So therefore it's as up to date as the current discussions, and we're keen to kind of have that open conversation with you today.
Thank you, Dom.
Just picking up on the CBC here. There's an absolute commitment to provide all of the existing diagnostic services that are provided at the Grays site. The national community diagnostics opportunities go further than having MRI and CT scanners. So it makes sense for us to explore that opportunity, so that we can bring additional diagnostic capacity over and above what is currently available. So that's why we're trying to align them, but it is, as I said, it's a national process. There's going through, but it's such overlap that an opportunity.
I'd like to pose I really appreciate your questions, because I share your concerns with the Grays owners. We were walked around and personally we sold these new buildings to materialise. Also, and there's still questions over like the art department, where that's going to go and work. So our next update, we had more detail apart from that. That's a public literally got.
Exactly that, Chair. In view of the technical problems and their time constraints, can we please, for the unasked questions, we forward them to Jenny and with your consent, have those answered and written replies back to the committee members, please?
So I do apologise for the hold ups tonight. We had the first technology delay, then we had the second delay in between. So I thank everyone for bearing with us tonight with the technical hiccups. Nice to see the hall again. One day the hall was real meeting real nice. But thank you. At 9:19, thank you.